So today we will be talking on hyperprolactinemia. So elevated prolactin in blood is called hyperprolactinemia. When it is elevated greater than 50 microgram per liter, we call hyperprolactinemia. So you know guys, the physiology, it is secreted from anterior pituitary. And this prolactin is under inhibitory control of dopamine, which is secreted from hypothalamus. So this is hypothalamus and it secretes dopamine, a molecule called dopamine, and this dopamine acts on these receptors on pituitary and it inhibits the secretion of this prolactin molecule, prolactin. So it is under inhibitory control of dopamine. So when you block this receptor, what happens? There is loss of inhibitory control and this prolactin is secreted in more amounts. Okay, so there is hyperprolactinemia. And when there is elevated prolactin, what occurs? That this gives inhibitory feedback to pituitary and it suppresses FSH, LH. So inhibition of gonadotropin releasing hormone, inhibition of GnRH, thus leading to low FSH, LH, and thus leads to low estradiol. Okay. So what are the conditions or etiologies of hyperprolactinemia? So there are some physiological states where you can get elevated prolactin in the blood, and there are some pathological states where you can see elevated serum prolactin levels. So what are the physiological states? So one is pregnancy, another is lactation, lactating mothers you can see elevated prolactin, another is after coitus, after sleep, after chest wall stimulation. In these conditions you can see elevated prolactin, and there are some drugs that causes elevated prolactin, like drugs like metoclopramide, methyldopa, calcium channel blockers like verapamil. So this metoclopramide is D2 blocker. Dopamine, if there is blockage of dopamine receptor, what occurs? The inhibitory control is lost and you get high prolactin in the serum. And methyldopa inhibits dopamine synthesis. So low dopamine means inhibitory control is lost and there is elevated prolactin in the serum. Okay. So there are some drugs that causes high prolactin level. And there are some pathological states where you can get high prolactin level in blood, like adenoma of pituitary. It may be micro or macroadenoma of pituitary gland, where you can get isolated secretion of prolactin or when combined with growth hormone or ACTH. Okay, so one is adenoma of the pituitary. Next is renal failure due to low clearance of prolactin. Another is hypothyroidism. Another is cirrhosis. So in these states also you can get high prolactin in the serum. So you have to check for these pathologies. Okay. So we talked about what is the definition of hyperprolactinemia, then what is the basic physiology of it, and then what are the causes of hyperprolactinemia. Now let's talk about what are the clinical features. So in female you can see infertility, amenorrhoea and galactorrhoea. So due to high prolactin there is galactorrhoea, and due to inhibition of gonadotropin releasing hormone you can get this infertility, amenorrhoea. Okay, and due to low FSH, LH and low estradiol you can see menopausal symptoms. So this hyperprolactinemia does not only occur in females, it can occur in males as well, but the concentration of the prolactin level in serum that is required for symptoms is more in males, because with the same level of prolactin, hyperprolactinemia, you get symptoms earlier in female compared to male. Okay, so that is another point. So those are the clinical features. And the mass effect of adenoma you can get mass effect. So when there is pituitary enlargement, what occurs? It compresses optic chiasma, and you can get bitemporal hemianopia. That's why you have to also check for visual field effect. Okay. Another thing is that this, due to mass effect, you can get headache, and due to this inhibition of the gonadotropin releasing hormone, you can get low FSH, LH. Okay. So what are the investigations you will do for hyperprolactinemia? Investigations. So one is obviously serum prolactin level. Another FSH, LH, estradiol, TFT, serum creatinine to rule out renal failure, and look for cirrhosis of liver with USG, PTINR. Okay. Talking about serum prolactin level, sometimes you can get falsely high serum prolactin, sometimes falsely low. So what are the conditions? Here you can get falsely low serum prolactin if the serum prolactin is greater than 1000 microgram per liter. You can get falsely low values, and sometimes these prolactin molecules aggregate each other, and in that condition you can get falsely high serum of prolactin level. So these are the investigations. So now what is the treatment? So one is medical management, another is surgical management, where you do debulking surgery of the tumor, and another is radiation. So we reserve the radiation only as last option. After, if the symptoms are not even controlled with debulking surgery, then we only go for radiation. Okay. So what are the medical management options? We have dopamine agonists. So these are cabergoline, bromocriptine. So cabergoline you can give 0.5 to 1 mg twice weekly, because this has a long half-life compared to bromocriptine. Here you have to give 0.25 mg thrice a day. So cabergoline has half-life of about 1 week. That's why you can give even twice weekly. So dosing frequency wise, this is more good or efficient, you can say. But cabergoline, before giving cabergoline, you have to do echo to rule out valvular regurgitation. So if the dose exceeds greater than 3 mg per week, then there is high risk of valvular regurgitation. Generally, for the hyperprolactinemia management, we don't give so much high dose, greater than 3 mg per week. But in case of Parkinson's disease, you might have seen that we can go up to 2 mg, 3 mg per week. In that cases, you can see these valvular regurgitation. Okay. So one is medical management. Symptomatic improvement, you can give dopamine agonist. Second is debulking surgery. When do we do this? When the tumor is large and causes mass effect, compression of the optic chiasma, causing severe headache. In that condition, you can think of going for debulking surgery. But even for macroadenoma, initially we give dopamine agonist because it shrinks the size of the macroadenoma very fast. Okay, so we reserve this surgery only if it fails to decrease the size. Okay, so initially you do MRI brain, and you have to serially do MRI brain. Even in 4 weeks you can do repeat MRI brain to assess the size of pituitary. And as I told you that radiation is reserved as a last option. Okay, so cranial radiation is done. So what are the take-home messages from today's discussion? So you can get falsely high and falsely low values of serum prolactin. Second is that not only prolactinoma is the cause of elevated prolactinoma. You have to also look for other pathology like hypothyroidism, renal failure, cirrhosis. If patient is taking any drugs that causes elevated prolactin like verapamil, methyldopa, metoclopramide, antipsychotics, okay. And what are the clinical features? So the main clinical feature is infertility, amenorrhoea, galactorrhoea. And investigations you will do serum prolactin level, MRI brain, you will do FSH, LH, estradiol level, and to rule out hypothyroidism TFT, to check for renal failure creatinine, serum creatinine, okay. And treatment is, even for microadenoma or macroadenoma, we initially go for dopamine agonist, okay. And we prefer cabergoline over bromocriptine, because cabergoline you can give 0.5 to 1 mg twice weekly, but bromocriptine you have to give thrice a day, okay. So dosing frequency wise, it is good for patient to take cabergoline, because it has only dosing frequency is twice a week. It has a longer half-life, about 1 week. Cabergoline has a half-life of 1 week. So even if you give twice weekly, it manages the symptoms of hyperprolactinemia. So hope you understood from this lecture. Thank you.